Wonderful. Good afternoon. My name is Alicia Frericks. I serve as President and CEO of Lutheran Services in America, and I want to thank each and every one of you for joining us for today's webinar, Partnering for Impact, Navigating a Shifting Medicaid Landscape to Address Social Needs. So we're delighted to have such a diverse group of stakeholders with us today in the Zoom room. And at Lutheran Services in America, our mission is to cultivate caring communities that advance health and opportunity for all. And when we talk about health, we talk about it in the broadest sense, mind, body, and spirit. Our network of 300 human service organizations reaches across 46 states, and they have been working in their communities for decades, and in many cases over a century or more. So our mission-driven, community-centered networks work across all the populations of Medicaid, including children and families, older adults, and people with disabilities. And we all know that evidence and data tell us that health, including behavioral health, is shaped not only in clinics and hospitals, but in communities. Access to food and nutrition, safe and stable housing, transportation, and other supports are essential drivers of health outcomes for individuals and families. Accordingly, over the past year and a bit more, Lutheran Services in America launched an effort to strengthen the connection between healthcare and social care. In this work, we were exploring how social service organizations can partner more effectively with Medicaid and Medicaid managed care organizations to address those health-related social needs that improve outcomes for those we work with in community. So in partnership with George Washington University, who joins us here as well today, we explored key questions that would provide important insights to inform how we continue to strengthen necessary partnerships, especially in a rapidly changing Medicaid landscape. So we asked questions like, how do we ensure access to critical services that prevent, stabilize, and enhance people's lives? And those questions led to an investigation that included 10 member case studies to understand the partnerships our members are leading in their communities with Medicaid and Medicaid managed care, and a couple of which are featured here today on our webinar. It also included a review of Medicaid managed care contracts in 16 states and health-related social need waivers and other payment mechanisms. So, while some of you all may be wondering and asking, is this the right time for this type of effort? The answer is clear. It is critical and urgent as Medicaid is undergoing a structural shift. A shift that continues to trend towards greater value and improved outcomes. And I have to say, we have a role to play. Responding to these changes and opportunities will require building and strengthening partnerships between social service organizations like the LSA members, community-based organizations, and Medicaid managed care. And as managed care organizations face increasing pressure to improve health outcomes while containing costs, and given the evidence that we talked about that 80% of health comes from outside the doctor's office, partnerships with social services and community-based organizations are essential. So the Partnership for Impact Guide that we're releasing today centers our discussion, and it really aims to synthesize the key learnings from this network and provides an essential structure based on existing evidence to advance core strategies that ensure social services and community-based organizations can strengthen their partnerships with Medicaid managed care to expand their impact and improve health outcomes for so many in our communities. So, as we look ahead today, especially with the fundamental shifts currently at play, we know that mindset shift is essential, and bold leadership is necessary to do things in different ways. Together, by strengthening partnerships, we can build the systems and community connections needed to truly advance health and opportunity for all. And now I'd like to turn it over to Sue Polis. Sue.
Thanks so much, Alicia. It's a pleasure to be with all of you today. And I am Sue Polis, as Alicia said. I am Vice President of Government Relations and Public Affairs for Lutheran Social Services in America. And it's my honor to really acquaint you with the Partnering for Impact Guide. So you'll see, many of you hopefully have already had a chance to download it. And if not, When you do have the opportunity, you'll see that the guide is really structured around four key strategies, which I'm going to focus on today. Each strategy includes uh, actionable steps, some context and background in each strategy, and then some actionable steps, including entry level as well as advanced, right? Because our aim with the design of the guide is really to meet social service organizations and community-based organizations where they are. Start anywhere, go everywhere, right? So each strategy really is through that lens, and then is followed by a Lutheran Services in America case study, or in some cases more than one, that really illustrate how this looks in practice. And so the first strategy that we really are going to talk about today is prove your value, lead with data. And in this strategy, our focus is really on key entry points, including developing internal data analytics capabilities, tracking payer and relevant metrics, as well as advanced pathways such as building a value dossier and exploring social return on investment. And as you scroll down, you'll see you can go right to the second strategy. Our second strategy, mastering the mechanics of partnership, billing operations and navigation. And this strategy, again, the rationale for the strategy, and then the entry points, right? Streamlining documentation, negotiating clear payment terms, investing in billing expertise, followed by a great example from our Lutheran Social Services of Northern California under the leadership of Carol Roberts. And then our third strategy, align services with value-based and alternative payment models. Again, the rationale for this recommendation, for this strategy, and then our actionable steps, right? The entry point really exploring in lieu of services and value-added services opportunities within Medicaid managed care, and advanced pathways such as monitoring state contracts and waiver renewals, and being open to shared risk. Again, followed by Lutheran Social Services case study, in this case, Lutheran Family Services in Nebraska and Iowa. And then finally, strategy 4, which is really about forging strategic alliances. Entry points, understanding the ecosystem. Secondly, in forming collaborative networks, and advanced pathways present a unified front. So I'm going to stop sharing, but we do encourage you to review the guide in more detail. And I'm just briefly going to take this opportunity to welcome our speakers for today. We have a wonderful group of panelists with us, including my longtime colleague, Stuart Butler, who many of you know because he's been working at the intersection of social determinants of health and health-related social needs for a decade, or really more than that. And Stuart is with the Brookings Institution, and he's going to be our moderator today. That is followed by our colleague Katie Horton from George Washington University Milken School of Public Health, research professor. And Katie, our partnership with GW has really brought to fruition this Partnering for Impact guide that we're going to review today. Next, Enrique Martinez Vidal from the Association for Community Affiliated Plans. When we spoke to Enrique early on about this work, he helped us organize a focus group with his member plans to inform this effort, and has also just provided invaluable insights as we've moved this along. And GM from Common Spirit Health, who has been leading efforts to ensure community-centered care through partnerships across the country through her important leadership role at Common Spirit Health. And then, of course, from the Lutheran Services in America Network, two of our key leaders whose work has importantly influenced the guide, including Hector Colon, President and CEO of Lutheran Social Services of Wisconsin and Upper Michigan, and Mark Stutrud, for Lutheran Social Services of Illinois, the CEO of our Illinois chapter. So now I'm really going to kick it over to Stuart to take us through this great discussion. Thank you.
Great. Thanks very much indeed, Sue. And it's a great pleasure to be here. And as Sue said, for the last 10 years or more, I've been looking at social determinants of health and the issues associated with it. And I can just say that that experience really underscores the value of this guide in terms of giving really effective guidance to organizations as to how to deal with these situations. Certainly, if you look at the last several years, 10 years or 15 years, there have been significant shifts in health programs, particularly Medicaid, and they've forced us to think differently about how to provide services and about innovation. So what I'm going to do is just touch briefly on a few of these sort of shifts and developments that have occurred that underscore the importance of the guide. And then we're going to hear directly from two of the Lutheran Services in America members, as you've heard, who are adapting to these trends and are leaders in that and featured as case examples in the guide. And then following that, we'll have a panel of other speakers who, from different vantage points, have been involved in this whole issue of how do we adapt Medicaid and how do we adapt to changes in the health system. So there are really sort of three patterns that I think are important to recognize and certainly explain the importance of the guide. The first, of course, is very obviously the changes in Medicaid, certainly in the last year and even before that, including new requirements, work requirements, changes in the program in a variety of ways. And that's forced us all to think differently about how to address health in our various communities and to think about other partners who can help everybody adjust to changes in Medicaid. Fortunately, we have opportunities like the waiver programs in the Medicaid, the 1115 waivers and other waivers and some new waivers, in fact, recently, that does allow a great deal of experimentation. And the important thing about that is not only that it's taking place, but the data is now beginning to really come in. We're beginning to learn from what's happened so far, and that's shaping the way that we can address the future. I think the second thing that's important is to recognize the importance of social determinants of health or health-related social needs. That Alicia mentioned that when you're thinking about health in a community or in a family, it's much more than medical care or even your immediately sort of healthy activities. It involves other things, transportation, nutrition availability, housing, and so forth. And so we're seeing a lot more attention to how various organizations that are in these other fields, like transport, like housing, can connect together with healthcare organizations to create much better health in communities. And that, of course, is, again, why the guide is so important to look at, to give ways and examples of how different sectors can work together. And then I'd say just thirdly and quickly, the other trend is an increasing recognition that if we're going to get both good healthcare outcomes and we're going to get effective collaboration across sectors, we've got to have partnerships. These partnerships require really measurable value, good data, so that different institutions can see why it's in their enlightened self-interest to collaborate. And we're certainly seeing social service organizations like LSAs developing data management and other technical capabilities to really show to MCOs and to other health systems why they are very important partners in achieving healthcare outcomes in those areas. So there's a lot going on. Some of it's driven by things we wouldn't want to see happening and anxiety, others by just our growing understanding in these areas. So let's now turn to a couple of the Lutheran Services in America members who have been partnering with Medicaid organizations and other partners and are really sort of trendsetters in this. And I'm going to ask them a couple of questions. And then if we have time, before we move to the next session, we'll have a couple of questions from the audience as well. Let me begin with you, Hector Colon. Could you just describe your work and the efforts at Lutheran Social Services in Wisconsin, particularly in the area of behavioral health, because I know that's been very much a focus, and the health partnerships that have been involved in that?
Yeah, thank you so much, Stuart. And it's an honor to be on this panel with you and the other distinguished guests. You know, we started off by doing some research and looking at how our managed care organizations were doing in here in Wisconsin, specifically related to the HEDIS measures. And we found out that they weren't doing that great. They weren't the worst, but they certainly they weren't the best. And so we found an opportunity to work with them, you know, those individuals that were entering costly services such as emergency room care and were poor outcomes specifically related to the HEDIS measures. So we partnered with Children's Hospital, specifically the Chorus department that oversaw the Medicaid managed care entity of the programming piece. And we started an intensive case management approach that had three goals. One was to reduce emergency room services. Two was to redirect those services to margin producing opportunities for Children's Hospital, but also to make sure that we're placing the client in the right service at the right time. In this case, it was intensive outpatient therapy. And then also, we wanted to make sure that we would, through these efforts, we would improve the HEDIS measures so the Children's Hospital can draw down those incentive dollars from the state. Critical component of this, has been mentioned, is social determinants of health. So if housing and food and transportation and safety and access to healthcare and mental health services, if they don't have that, they are not going to be successful. And so that's where our sector and our organization specifically played such a critical role in making that connection to healthcare, to social care, which led to great results that I'll share later on in the discussion.
Great. Thanks so much, indeed, Hector. And let me turn to you, Mark. If you could just also describe briefly your efforts in Illinois, and particularly how you work with partners in care coordination and reducing the costs and improving outcomes.
Yeah, for us, it really started about 12 years ago. We began to explore what value-based and performance-based provider care would look like. And at that time, we had a grant that we received and used it to engage Optum in that discussion. And so they were really kind of guiding us in our thinking. And we began to think about the limitations of that current status of Medicaid reimbursement, so regulative and focused, and to units of service and to crisis transition or symptom reduction or just, some level of basic functioning. And we wanted to do more because we knew that the populations that we serve, whether it be in disabilities or behavioral health or child welfare, historically have a disproportionate utilization of total health care and cost. So how do we not only affect that, which is important, of course, but how do we also help people live their best life? Because we know when people are living their best life, when we turn a corner from the crisis or people being the sum of their crisis or people being, their symptoms or their behaviors and being defined by that and routinely going in and out of acute care service, that's when the corner is turned and that's when total cost of care costs go down, but also the person's life changes dramatically in positive ways, and we can measure health and well-being in ways that are much more impactful. So with that thinking, then we began over time to approach managed care organizations. We've approached our Department of Child and Family Service and redesign of child welfare, foster care, and also in services to senior adults with managed care organizations who receive home care. And those three areas have been, our primary focus. We've been growing with them. In the case of behavioral health care, there are two parts to it. One is community certified community behavioral health clinics, but also earlier our engagement through our partnership with Centene, with 35 other providers in the state of Illinois. Centene has just been an amazing partner, and I see. I believe it's Karen Rogers in the audience, but Centene really invested in a model and co-created with us as providers a way to get at the impact of health and well-being and to reduce significantly total cost of care. And so that's something I can talk about in more detail, but that's really been our approach, our engagement. And our view is really three things that we want to accomplish. How do we truly promote the dignity of the person? How do we enhance health and well-being? And then thirdly, how do we help people reach full potential, realize hopes and dreams however you want to, but again, how do they live their best life? And we're much more generative in how we engage, surround, and connect with people.
All right, thank you, Mark. I just want to emphasize to people who are watching the seminar that if you have a specific question, please do put it in the chat. Ideally, a brief question, but please do that, and we'll try to include some of those as we go along. But I want to go back to you, Hector, and actually to both of you, really. And I mentioned in my opening comments about the importance of data and understanding data and data capacity and so on. And in order for you to get effective partnerships, I'm assuming that you have to be able to demonstrate in pretty concrete terms sort of why that partnership is going to be valuable for everybody. And so I wonder, first of all, Hector, if you can start by saying you're getting what seem to be very exciting results. How do you use data, first of all, to find those results and to monitor them? And what are the results actually also telling you? I mean, are you seeing sort of patterns and trends that others ought to be really aware of and ought to be looking for?
Yeah, thank you. So for us, we started this partnership with Chorus, and we started with 50-50 in terms of paying for the cost. That was year one. Year two, they ended up paying 75%, us 25%. Year three, they paid 100%. And then year four, we were going to move towards a value-based approach. Unfortunately, in full transparency, I want to say that the partnership has been paused because they lost $25 million in the exchange program, which is unrelated to this. But they essentially handed the data that I'm going to share with you. So it was data that they have data, we have data, but the data I'm going to share with you is directly from them. And one of the learnings here is that going bigger, because this was a small pilot, but going bigger would have been more dramatic and probably harder for them to walk away at this point, even though they needed to refocus their efforts. So with the population that we serve, we were able to decrease costs with those individuals by 19%. We were able to redirect services and margin producing services, intention outpatient therapy by 169%. And one of the HEDIS measures, follow up within 30 days, where globally in Wisconsin, the providers are around 71%. We were at almost 90%. So as a result of those HEDIS measures, that outcome, they were able to draw down incentive dollars from the state. So those were some of the outcomes that we had. And this is a perfect combination of mission, where we're serving individuals who are falling through the cracks, but then also an opportunity to create nice margin. If you move into the value-based approach with these providers, there could be a nice margin.
Can I just make sure I understand what you said at the very beginning about the data and the collection? Is it that were you saying that the partner was actually the main data gatherer? So in other words, part of the partnership was your partner really providing you with capacity to develop data that otherwise you might not have had or didn't have. Is that correct?
It is correct that they
Okay.
were the ones that had more of the information that could
Right.
give us this data. But we also had, we're tracking our own
Sure.
stuff. But yes, the information that I gave you was directly from Chorus.
Because I think that's important in terms of understanding that who does what in a partnership needs to be kind of thought through. And sometimes one partner is actually better able to provide a certain service, in this case, data, than the other. And I think that gets you, I think as you get further along and kind of looking at these things, it helps explain some of the challenges sometimes when you're dealing with, say, government agencies that don't necessarily aren't allowed to share data or and things like that. So that there are a lot of difficulties there. Let me go back to you again, Mark. And again, I'm just any of you want to ask a specific question, please put it in the chat. But Mark, tell us a little bit more about how you are monitoring results and the progress you've had sort of more broadly from your work.
Well, it really isn't a range of metrics and sophistication, and depth. And, I would say, on the our in-home senior service pilots that we've been running in the sense of our partnership with MCOs, it's kind of on the light side of data because we're not looking from a value-based proposition to really gain share in any type of cost, that we might be reducing in hospitalizations or emergency room visits. But we are seeing that the quality of life for the seniors being served in their homes is improving. And we have metrics that demonstrate that improvement in their well-being. But then, you go into the redesign of foster care that we've done, and that's in its third year, and we're working directly with the Department of Child and Family Service and the metrics, in reduction of lengths of stay, the increase in placement stability so that we're not jumping from foster home to foster home as one example, and the increase in the level of functioning for children in trauma or their overall well-being, and even in the increase of positive predictive parenting skills, that we see that are a basis. And then you go into the more sophisticated, the CCBHC, there are over 21 plus quality measures that, we track and have to report. And we're just now getting into a relationship with another organization that will do the independent review of those quality measures to make sure that we're not, solely doing the counting of them, the evaluation. But then the most sophisticated relationship has been the partnership with Centene. I mean, when do you partner with an MCO who has all the data and all the adjudication process and everything that's going on? And really the goal is to reduce total cost of care. That's so critical. How do you have integrity of data? And that partnership has really provided it. And also the activities, as they've been paying for us to co-create a way of approaching health and well-being from the most important activities and the metrics, the HEDIS measures, the follow-up on hospitalization in 30 days, but also the readmission process and how do we establish mobile crisis teams, that are effective in that readmission cycle, and all the other things that happen on a daily basis. And we're constantly creatively working with them from a partner perspective on how do we think about things differently in the health and well-being of individuals. How do we increase their natural setting where they want to be safe and secure and a place where they thrive. And, we're seeing a much broader increase of outpatient care and community-based care and a drastic decrease in inpatient and hospitalization and emergency department visit.
There are a couple of questions in the chat, which let me just put to you both, really. One is just a question saying, is the data collection generally that you're using sort of Z-code based in terms of looking at these social determinants? And then a question from Alison Ryan at Quantified Ventures to you, Hector, about the partner walking away and whether you think that's more likely to happen when the outcomes being measured are more process related rather than, I assume, rather than financial.
Yeah, I can answer that question if you like. Thank you. So, we did demonstrate cost savings, like I mentioned, 19%, and we did improve those HEDIS measures, so there were financial incentives there. Now, in full transparency, we don't know how much they received in those incentives, but we have asked for that information, and they said that they would share that. So there was financial savings, there was improvement in outcomes with regards to our partnership. Again, the very specific reason is they lost 25 million unrelated to this program in the exchange program,
Right. Mm-hmm.
and they had to get really focused from the top leadership. They wanted to get really focused. So it's more of a pause,
Mm-hmm.
but there were better outcomes and financial implications, positive implications as a result of the partnership.
Mm-hmm. Mark, do you have any thoughts on that as well? In terms
Well,
of,
really,
well,
the
I was going to add in terms of just the information on the financial outcomes itself seems to be a critical point here, in terms of privacy, if you like, or certainly in terms of corporate responsibility and so on. But what's been your experience?
Well, back to the relationship in the Illinois Health Practice Alliance with Centene, that has been probably the most in-depth. And certainly we have several contracts that differ slightly in the sense of pay per performance on key metrics by providers. And so they're tracking, success or lack thereof in the sense of achieving those metrics, and then we're paid accordingly on an incentive basis.
Mm-hmm.
And those particular metrics, I can't really get into detail the intellectual property of Centene, toward this. But you can imagine that they surround, the HEDIS measures and the most important things that have to happen, actionable items that have to happen that we know through research have an impact on health and well-being.
There's an interesting question in the chat from an organization that's primarily dealing with refugee resettlement, and it's basically asking, how do you know which is the right partner? How do you find out this info? Is there some kind of way of doing this? Is it hit and miss? Is there some intermediary that you can turn to? I just wondered, in both your cases, what led you to that particular partner?
Well, for us, it was a organization that aligned with our values,
Mm-hmm.
wanted to make a great credibility and reputation in the community, and was really wanting to make a difference in the lives of the people who today were falling through the cracks. And so that led us to this organization, and will lead us to other organizations that have similar missions and
Mm-hmm.
purpose in mind.
Okay. And Mark, what?
Well, as I've described, I mean, we serve a broad Medicaid population.
Uh-huh.
Kids and child welfare, families and kids and child welfare, senior adults, duals in that sense as well, and directly in the Medicaid behavioral health group. But there are ways of indirectly entering into value-based agreements and moving into structured alliances that really help. Like one example we've done in that regard is we're embedded in 5 community safety net hospitals 24/7 with behavioral health services to help, triage and divert, a population that otherwise could get in the way of someone with an acute medical emergency. And how do we, because things can get pretty jammed up, inside of that place. And so providing value and having access in that regard has been very good for us as an organization. Yeah, but it also has been good indirectly back to the relationship in the Illinois Health Practice Alliance, and the sense of keeping people out of hospitalization, and that same population and zip codes are kind of overlapping. And then it prepares us for the future because we're always in a place where we're upstream of the difficulty or the crisis, and we're better prepared as an organization in the eventuality that we get into a direct relationship.
Right. Well, thank you both very much. There's still some more questions in the chat, but I think we'll need to move on now. I really appreciate you taking the time to fill us in, and there's lots of questions I'm sure that maybe you can answer later on with some from some of the individuals. So let's now move on, if we can, to the panel. Again, thank you. And we have to take a broader view now. We have a panel of three here to talk about how some of this experiences of to strengthen cross-sector partnerships that are moving forward. And I'm going to start with just a quick question to each of you, the same question really, to ask you about your experience so far in terms of seeing these kinds of partnerships on the ground. So let's start actually with Katie, if she's available. Here we go. I see Katie up there. That's great to see you. So I'm going to ask each of you really to just briefly describe your organization, sort of what your role in the in this project in the guide, and in terms of aligning health and social care and the issues needed.
Well, terrific. Thanks, Stuart. Our research team at the Department of Health Policy and Management at the George Washington University School of Public Health, we had the real privilege of leading the research and development of the Partnering for Impact Guide. This was all part of the Lutheran Services in America Strengthening Families Initiative. I just want to note quickly an important role that two of my colleagues played. Aaron Karkachansky and Greg Dwyer really helped lead this research, and so grateful to all of their good work. So I think you were really asking, why is it important to align health and social care? It's really to reinforce, I think, what you said earlier, Stuart. It's healthcare alone can't improve health. Not when the drivers of poor outcomes are overwhelmingly social, economic, environmental. So that aligning that healthcare and social care, it's not a feel-good idea. Like, gosh, if we could only provide meals, or if we could only get someone. It's not a feel-good thing. It is absolutely a structural necessity if we want a better outcomes, lower costs, and provide a more equitable system. And I'll just wrap up by, in my mind, I think about, if a patient with asthma living in a mold-infested housing environment, or a patient with diabetes can't afford food, no amount of clinical care can compensate for that. So really aligning those health and social care factors are critical to the outcomes.
Right, thank you. And we'll come back with some other questions on the research side as well. Enrique, can you just tell us a bit more about the Association for Community Affiliated Plans, and also, again, why aligning health and social care you think is so important for the plans that you represent?
Sure. Thanks, Stuart, and thanks to Lutheran Services in America for this opportunity to really participate in this important discussion. So our association, ACAP for short, we're a trade association of 90 nonprofit health plans. They all have Medicaid contracts. They're really in the community. They were created by federally qualified health centers, children's hospitals, local government, community, county governments. They're really close to their members in the community. They've really worked on trying to address those health-related social needs of their members for years and even decades, but most of the time it was very organic and ad hoc, just finding a population here that had a need, et cetera. More recently, we've been really working with our plans to be more intentional and structured about it, and helping them understand where they were in their journey, and to develop and improve those aspects. And some of those major areas were, how do you develop those internal structures and resources and leadership, and set those priorities? Those competing priorities is a really critical thing. I think a shout out to Hector and Chorus. Chorus is one of our members. Just just an example of those externalities that impact, it probably had nothing to do with your project and that initiative, but those externalities can have a huge impact. Another big area, and I think this is another place for partnerships, is the data collection and analysis of member needs, not only just through all their mechanisms, but through your mechanisms, through the CBOs and the social service organizations out there in the community. You have a lot of information that plans may or may not have. Data is really a two-way street. It needs to flow two ways. Developing and those appropriate programs and those partners, that's sort of like the third step once you figure out what those needs are. And then probably the hardest thing that we've been working with our plans in is how do you measure the impact of those investments. And again, some of that comes back to data, some of it comes back to partnerships and just understanding what's happening in the communities. So why alignment? Well, as everybody's already mentioned, we know that addressing health-related social needs can improve the overall health and well-being of members. But if done correctly, and it's been noted already as well, it can impact clinical quality measures, member family satisfaction, and finances. I mean, we talk about ROI, but that's not the only impact. In fact, we try to get our plans to think not just about financial ROI when they think about impact. All those are critical goals for health plans. Member retention, enrollment. So those partnerships that can help plans address member health-related social needs are really critical at the front end, supporting that data collection and identification of the needs, co-creating and supporting those initiatives and investments, as well as supporting the understanding and the measurement of those impacts of the partnerships. So I'll stop there.
Hey, it's good to see you, G. And you, of course, are with the largest Catholic health system in the country. So tell us not so much about that, but about the particular group that you are working with in the community and population health area.
Yeah. Hi, everyone. It's a pleasure to be here. So I am with Common Spirit. We are one of the largest nonprofit Catholic hospital and health system. We're in 24 states, more than 140 hospitals, and 2,300 care sites. The one sentence that really captures all this for me is that urgent care services alone cannot build thriving communities. The hospitals and EDs and these subspecialty centers cannot alone build thriving communities. This really has to resonate for all of us. And so the work that I lead here, we coined it community-centered care, because so much of the work isn't about what we do in the hospital or clinical settings, which is screening for the social drivers of health or the health-related social needs and making referrals. It's not about screening and referrals. This is about whether people are actually receiving those services and experiencing the transformative care when many different sectors really align together and work together. And so what we have really focused on is investing in that community infrastructure, the community capacity, and the community workforce, including community health workers, who we believe are necessary to translate the policies, the procedures, the things that need to be done into action, co-creating those solutions with our community partners and exploring new opportunities for funding and collaboration. So this isn't about just, again, screening and referral for us. This is about building that infrastructure that's needed in the community so that people do get the resources, so that people do get the services. And at the end of the day, when many different sectors work together, that's when we're going to see holistic care changing for people, individuals, and families.
Can I just quickly follow up? And it's not immediately obvious that the health system finds it in its enlightened self-interest to spend money and invest in the local community in a direct way. Do you feel that the faith-based organizations are a unique sector in that, or do you think that's something that um, is beginning to be recognized in other health systems?
Yeah. So I think that we all think that we're unique and special
Yeah.
in doing this work. I will say that being mission oriented, definitely a lot of this work isn't just to say we are a nonprofit hospital and health system, and for because of that we do XYZ. We do that because of community benefit. We do that because it aligns with our mission and our values. And we do it because we're an anchor institution. And what I mean by an anchor institution is that we don't go away because we can make money somewhere else more, right? On a whim. We are anchored in the community as a physical capital where we are hiring locally, we are investing locally, and we're purchasing locally. And those are the commitments that our organizations have made.
Mm. Let me turn back to Katie. You've been so involved in looking at the research work on this in terms of the guide and elsewhere. Are there sort of bottom line research conclusions that you've drawn that you think are particularly important in helping various organizations to understand the potential of partnerships?
Yeah, I think one of our concluding findings from the work really, and what we hope the guide provides to social service organizations and community-based organizations, is that these folks are not merely vendors delivering services, right? They are not delivering just discrete services, but they're really essential community infrastructure. They have a sustained presence, to G's point earlier. They have trusted relationships. We heard time and time again how invaluable that is. The ability to reach populations that traditional healthcare systems often struggle to engage, really make them indisposable, and helpful to the strategies aimed at managing populations. So when I think managed care organizations and states partner with SSOs, they're not just purchasing those services, they're investing in the infrastructure that extends their reach and stabilizes particularly high-risk populations. So I think that's one key takeaway. There's so many, but I would just say, Stuart, to emphasize the point you made earlier, Medicaid landscape is so rapidly changing. It's not going back to fee-for-service. We are where we are. Partnerships have to be designed for long-term sustainability rather than treating current policy changes as just temporary disruptions. It's time to sort of arm up and get ready for this phase of value-based care that we're entering into. I think becoming an indispensable partner rather than just vendors. Social service organizations have to lead to measurable data, something we've talked a lot about. It's really important to be able to quantify how social interventions are reducing high-cost care, such as emergency department visits and hospital readmissions. Being able to put numbers behind that experience, super important. And I think the final thing I might mention is, MCOs need partners that can manage populations across broad geographies. What this might mean is really coming together, not just to partner with MCOs, but to partner with other CBOs, other SSOs, to share best practices, to pool resources, to increase negotiating power at times, might be an important factor coming out of this research. I'll end with that. Thanks.
Sure. Katie, there was a question in the chat about screening and the disconnect between effective screening of what somebody needs in terms of non-medical services that affect their health and people actually receiving those. My understanding of the research is that, that's a big gap, and that the trust is really, in many ways, the critical ingredient. If the referral is coming from an organization that they trust, then it's more likely to happen, which might underscore the value of partnerships, that a partnership might include an organization that is well known in the community, And by there being a partnership with another, with say a big health system that might not be so familiar to them, that local non-health organization, that SSO or CBO, sort of credentials the referral. That is that you're nodding, so I think the answer is yes. But I'm was asking if the research that you've done and your experience with this guide sort of underscores that importance that in a partnership, each partner has some important value. One may be the trust bearer.
Right. I think you're absolutely right. We saw time and time again when we were interviewing folks for the case studies that ability, that trust, being at the local level, the ability to speak to an individual and have that individual trust the social service organization to share, for example, maybe they are having trouble with food insecurity or housing insecurity. It really makes a difference who's asking those questions. And
Yes,
we saw
yes.
that in the case studies.
Yeah, I think that's a really important point and one that really undergirds the importance of partners that play different roles and are better together, stronger together. Enrique, maybe I can ask you the same question in terms of the organizations. Have you found the same kind of experience? And also just sort of generally what is important to get the partnerships that you see off the ground and to get SSOs and CBOs involved?
Yeah, I mean, I would agree with what's being said here. I mean, developing those trusted partnerships is a really critical aspect to that. And so completely agree. I think that gap between what is needed and what's understood from assessments and what's being delivered on the other end, it goes beyond that though as well. I mean, there's a lot of capacity issues, there's technical issues. So, I think if I've been trying to frame it around, value, the value of these partnerships. And I really think it's good to think sort of broadly about value. What is the value of those partnerships and those relationships? What's the value of the services that are being provided? And how do you even measure value? Value to who? Most importantly, we're mission-driven nonprofit plans. We think the value means improving the members' overall health and well-being. That should be the core of this work. So looking at partnerships to address those needs and increase value, we actually surveyed our plans a couple years ago to try and find out what the biggest technical challenges in developing and maintaining those community partnerships were. And I think what's fabulous about this resource is that it addresses a lot of these concerns.
Yeah.
They felt that there was either real or perceived limited CBO capacity out there. So that's a challenge. You can ask your members all day long what they need, but if you don't have the capacity in the community to serve those needs, that's going to be a challenge. And then the providers don't even want to ask the question. There is also unclear sort of benefits and ROI for the partnerships or the services. Again, this is really addressed in the resource here. The toolkit's fantastic. And related to all that was insufficient data and analytics, and we've sort of referenced that all through this conversation today. So maybe just to wrap it up, I have a lot more details I could provide, but looking at the big picture, I think the things that are really needed to improve these partnerships is to focus on two big overarching challenges. One is the infrastructure that's needed. Katie mentioned that, the mechanics of data sharing and personal health information security, privacy, business associate agreements. Can they integrate into platforms? The process of becoming a Medicaid provider that varies by states. All those sort of contractual challenges that happen, and then overall the financing of the whole thing. So it really, to me, it comes down to measuring the value of those investments and partnerships. I mean, there's the old trope, no money, no mission, but value, again, as I mentioned, we try to get our plans to think beyond just the financial ROI. How do you look at the quality scores, member retention and engagement, member satisfaction, some intangibles too, sort of goodwill and reputation in the community, value of those relationships with their partners in the community and with the Medicaid agency. So there's a lot of places where these partnerships are of huge value and actually will make these initiatives be successful.
I think you underscored the importance of looking beyond strictly the health results or the savings in the community. And I think that dovetails very much with what you said, G, at the beginning, that you're a health plan that just doesn't see itself only as providing healthcare to people. It's a partner, it's an organization within the community itself. I wonder if you kind of elaborate a little bit more on how Common Spirit and how your work in particular is shaped by that. Particularly the community care hubs that I know you've been involved in organizing and thinking about, and the community bank, which is an intriguing idea. Which, if you could take a moment to explain that, sort of how you as a health system become involved in the community, and then maybe sort of how that affects what you think of as return on investment. Because I'm sure it's not just does it improve the bottom line of Common Spirit. A return on investment is much more broadly measured in your sense, I assume.
Yeah, it is because we're not leaving. We're here to stay, and we're taking care of our families and friends and neighbors. And so at Common Spirit, our experience with doing the work around establishing community care hubs and catalyzing more community bank models, which is a way for multiple stakeholders to saying, how can we put dollars in? Because we know what we want to do is going to cost a lot more than what one of us can afford to pay to do, right? And so how can we share our assets? And these assets can be financial assets, but it could also be the workforce, and it could be the different capacities that community organizations can bring or healthcare organizations can bring. And so how do we come together around doing that work and financing it together? And so what our work has really reinforced is that this that there needs to be these strong alliances that need to be created between healthcare and social service agencies and public health organizations. It's possible to do, it's necessary to do. But what it requires more, and it's a theme that's across all the speakers today, is that there needs to be more intentional infrastructure. And so a few key lessons that really stand out for me in this work has really been around, first, these intermediary models like community care hubs are essential. They help organizations and networks of community organizations come together so that health systems and MCOs can engage at scale, right? So it's not one-on-one interactions, but at scale, one to many, and moving beyond that one-off partnerships, and then to ensure greater accountability for everyone. Take a look at the resources created by the Partnership to Align Social Care. It's a national action and learning network around aligning health and social services and social care. U.S. Aging and Disability Institute. There's the Center of Excellence to Align Health and Social Resources. A lot of really great resources there. Second, through our community bank, we've seen how critical it is to align financing with community capacity. And so CBS are best positioned to do this work, and they need to be sustainable. We can't be like, oh, grant dollars, philanthropy is going to fund all this. No, it can't. And so how do we transition the work of using our community benefit, community reinvestment dollars, local foundation, charitable dollars, and use that time as a runway to creating more sustainable models that allow for contracting to happen? And I would say that some resources that are good here is of unlocking financing for community health and equity. Health Begins, they're the Coalition for Health Equity Investments and Financing. It's a catalyst platform that highlights various different types of financing models that people have gotten. People are getting really creative, and it's about learning how are others thinking about doing this. There isn't one path, one way of financing this work. And lastly, leveraging what is out there. Leverage the partnerships with other sectors. Take a look at Common Health Coalition. They bring healthcare leaders and public health leaders together. The Convergence Center for Policy Resolutions, projects related to forming alliances and building trust. A lot of what has come up here, and also leveraging the data and evaluation. I keep telling people, take a look at the CMI Accountable Health Communities model, that the evaluation that shows that doing this work, providing resources and providing that navigational support, it generated net savings of more than $200 million. And so this is the key element of that work was really around human relationships that the navigators provided to individuals and families. And that's the work that a lot of the CDO partners are already doing today. So the bottom line is to build on the strong evidence and partnerships that are already out there.
I think Sue's just reminded me that several of the organizations you just mentioned are also included in the guide. And so you can find more information on those and get in touch with them. I think one of the things that you all really underscored this is that when you're looking at value and return on investment, it's not just, dollars saved or dollars earned. And it's not just, for most of these organizations, the areas that directly affect their service activities. It's seen in a broader community ways. And chief financial officers at health plans don't always see these things that way, understandably perhaps. But it's important really to kind of think about how do we measure these non-cash or non-direct returns on investment, and then how do we set up partnerships where there's an anticipation of this in some way that shapes who puts what into the pot to get a project going. I wonder, Katie, in terms of just the research capability in this area, this may be a bit of a curveball to you, but in terms of sort of this idea of a social return on investment, and how do you when a health system invests in something and it reduces homelessness, right? There's clearly a value to the community, but it may make no impact at all on the bottom line. In fact, it may reduce the bottom line of the health system. So in terms of the research in this area, how far are we along in terms of being able to indicate to organizations the potential return as they think of return in this? Are we still a ways from that? I get the impression we are.
Yes, it's a great question. I think I've had some long talks with LSA about this. As we wrap up the work, what's next? We certainly know the challenges with sharing data. Some of their members need help with that. But this whole field of measure development, measure evaluation, really in its early phases, it seems to me, particularly in the social service sector. I know there have been some early attempts to begin to come together and develop measures specific to social services, but it's greatly needed.
Yeah, I think we're on the brink of some really interesting experiments, I hope, in terms of how you develop a partnership that recognizes these different values, including things like my colleague, health expert Len Nichols talks about a bidding process, so that you have a proposed partnership or proposed idea, and then each of the partners is asked to kind of almost write a sealed bid. What if this partnership was to occur? What would be the value to you, and how much are you prepared to, or what are you prepared to do to make it happen? And so each partner is using a different set of measures as to why it's it's valuable. So I think that's maybe a way to look at it. Let me just ask, there's so many points in the chat now that it's hard for me to keep up, and we're running a little, getting closer to the end. So I just want to ask a kind of a quick question for each of you. I mean, if you can keep it down to just a couple of minutes each. You've looked at the guide, and I'd like you to kind of just say from each of your perspectives, what stands out as the most essential or a highlight from one of the 4 strategies that you think is particularly important in terms of affecting alignment and outcomes of people on Medicaid. Maybe I can start again with you, or with all of you actually, just kind of run through this is a quick fire session to kind of, what is that jumped out at you? Said, that's exactly what we need to do. Let's maybe begin with Enrique.
Sure. And because I'm a rule breaker, I'm not going to only pick one. Sorry, Stuart. I mean, it's a fantastic resource. Congratulations to LSA and to Katie at GW. It's really fantastic. All of those strategies are important, and they're actually all interrelated. I can't remember if it was on this conversation or before we got on, that they're kind of linear too. So it's a nice way to sort of follow through. But to me, it comes down to 2 overarching things: the relationships, this is what we've been talking about, and the technical aspects of providing those services. And these days, as you mentioned, Stuart, under HR1, plan resources are tightening up. There's lots of challenges, lots of competing priorities. So it's really important to me. I think the number one, I guess, if I'd say, is to prove your value with data and ROI. That first one. Come to the table with your strengths. Identify the gaps in care that the plan members might be needing. Talk about your current role in the community with the plans. Plans are looking for partners to do great work in the community. They don't want to reinvent the wheel if they don't have to. Share your mission. See how show how it aligns with the plan's mission. And then the other critical thing is talk to the plan about the quality of the work you do. They have a hard time understanding and measuring the quality of work that you're doing. They have a hard enough time figuring out the quality of their clinical providers, to say nothing about their community partners. So I'll leave with that one.
I see that there's several people in the chat are offering their ideas too, so that's good. Let me move to you, G. What's the one bottom line that you really see?
Of the 4, I think that we all want to start with the 4th, around forging strategic alliances for scale. Do not, forming those collaborative networks. Don't do the work in a silo. Well-intended fragmentation is still fragmentation that our system can't build upon. And so building these alliances, I would say that given our environment right now, walking the path to understand, there's a difference between knowing the path and walking the path. And what I mean by that is hospitals are going to get inundated with different problems, maybe even pre-ACA day problems. And I think it's not just about ROI. It's about how do these relationships and these collaborations mitigate some of the pain points that hospitals and health plans are going to face. And so the narratives, like kind of switching the narrative a little bit about, well, how can we work together to alleviate some of those pain points that that people are going to be experiencing right off the bat at the end of this year, next year, and how can we be partners to that? And so talking about that narrative is also really important.
Great, thank you. Mark, can I get you down to one item, or what would you say?
Yeah, I think it's first, as an organization, identifying our North Stars. What draws us, what pulls us. As I mentioned earlier, it's about dignity promotion, health and well-being, and reaching full potential. All researched outcomes that are demonstrated to be connected to the health and well-being and the dignity and the vocational aspiration, or whatever it might be, realizing hopes and dreams. And it's essential to persons in that sense. And then taking a look at the regulative environment we operate in, break out of that. It's like a chain, and what we did 10 years ago is we began what we call the movement to generative human service. So we weren't going to operate as a regulative organization. We're not an agency of the federal government or the state government. We're an independent organization. We will decide, how we can best, create greater impact in the lives of people. And so then from there, we went into, the framework, a development of a framework, a generative framework, a platform, and then, into a portal and operating system. How do we engage, surround, and connect in ways that take us in the direction of our North Stars? And then we're prepared, across the board for all different types of Medicaid populations to begin to provide greater value and to begin that relationship. But without it, then we're reacting.
Right. I like the idea of the North Star, and it seems to me it's the corollary in a way of talking to a person in the community rather than saying, what's the matter with you? Say, what matters to you? Because that really helps guide an understanding of what's needed to make this person healthy. Let me turn to you now, Hector.
Yeah, thank you. I would say prove your value through data and return on investment. My team and I were pretty forward-looking 9 years ago when we said we wanted to make sure we were improving the lives of the people we serve. So we went above and beyond what our contracts were required, and we started looking at the social determinants of health. So we have a lot of information related to that we can share with providers, and that is an advantage, I'd say. Now, my team and I are talking about what do we need to do next? And one thing that we're thinking about is looking at the Medicaid contracts and what are the HEDIS measures that they're being held accountable to. And how could we, with all of we serve 30,000 individuals on an annual basis. And by the way, the individuals we serve are the most acute with incredible odds, with no insurance. So
Right.
can we track them? What is their emergency room utilization? I bet you it's way better than the comparable population. If they go to the emergency room, how effectively are we responding within 30 days? So those are two examples. So my team and I are starting to look at this, and do we now start tracking a new set of data to help us position ourselves even more effectively with providers? So this really is about demonstrating our sophistication, our readiness, and ultimately our results, which will be very attractive.
Great. Thank you. Let me end with you, Katie, in terms of your key one.
Well, maybe just something we haven't talked as much about. I think sort of a pitch to LSA members. Get to the table, right? Don't get handed something. Sit at the table, and I think Mark referenced his work with Centene earlier. Help shape the initiative. And part of that is all of the things we talked about, having your data in order, having good IT systems in order, but having that capacity to both sit at the table and then also to identify opportunities for partnership. Even if you don't have the capacity to do things like monitoring Section 1115 waiver proposals and state managed care contracts, LSA does, and they are doing all of this good work for you. So knowing what's coming up and figuring out how to get to that table ahead of time and influence the initiative is super important. Thanks.
Very wise words, and wise words from all of you. And I just want to thank you so much for taking part and being involved in this really important guide. And then let me now turn it back to Alicia for some final words.
Thanks, Stuart. So happy to have this great discussion today and for your time and leadership. And we did put it in the chat, but please review the Partnering for Impact Guide in more detail. We really want to make sure that it's a great resource and tool, and share it with your colleagues, share it with your partners, share it in your organization, share it with your boards. And we did record today's session, and we will be sending this out along with a link to the guide. And if any of your questions didn't get answered, please use our email, which will be included in that wrap up. And we'll be happy to follow up. And I just want to thank everybody for their preparation and time to be part of this today. Please use Partnering for Impact. Thank you.
And thank you to our guests. Thank you, Katie, Stuart, Hector, and Mark, and Enrique, and G. It's just been great to have you all today. And thank you, Sue, and the team under her leadership. This has been a long time in coming, and so it's been great to see this come together. And we hope it's a useful tool, and we look forward to carrying this forward. We've got opportunity, and we've got a challenge ahead of us, and so looking forward to seeing how we can build on this. Thank you all for your time today.
Thank you.
Bye.